Christian, what's going on, man? How have you been?
Been very good. Working like crazy, doing the private practice stuff on Fridays and Saturdays. So I work Monday through Thursday, and then I have that. And then all day Sunday is going to be making the podcast and then more computer work, which is great, but it's also detracting from my training. So I
Mm,
am trying to lift 4 days a week, run two, climb two. And the last few weeks, I've only been able to lift about 3 times a week, which really sucks. But
yeah.
I'm dialing in the routine. I'm going to be getting there. Uh, yeah. But I did sprain my A2 pulley on my left middle finger. So that's a very common climbing injury, and I'm actually kind of excited that I did it because now I get to experiment with other treatments that I haven't done in a little while. So for example, I've been dry needling it with
There you
stim.
go.
Yeah, so I'm
Yeah.
putting 2 needles in it, hugging some stim up to it, and then just letting that do its thing for 10 to 15 minutes. I don't know if it's doing anything, but it feels better after. And then, of course, just
Yeah.
having a more sensible loading progression. Because the reason I got the sprain was because I was going way too hard, way too fast. Like I knew I shouldn't have. I just couldn't
Yeah.
help myself. And so here we are.
Man. You're always in top gear over there. If it's with work or climbing, whatever it is. That's some
All gas, no
ambitious
brakes,
training
Eric.
goals. There you go, man. Four days of lifting, some running and climbing. You got all your bases covered.
Yeah, well, I'm going to Denver at the end of July for a weekend with the old fraternity brothers, and we're going to be
Okay.
hiking 1,000 footer. So I got to make sure my cardio is at least halfway decent because I'm going to be going there from sea level without any acclimation time. So it's going to be a little gnarly, I think.
Dude, don't get that elevation sickness and
I hope not.
get put out. I remember when I was a freshman in undergrad, that was something that our physiology professor was talking about. And he had a story about he was hiking some mountain, I don't know where, but he said that there's a student that got like really bad elevation. Is that the right term? Elevation sickness? I
Altitude.
can't, I, altitude sickness. There we go. Yeah. And like this person like almost died because they had to rush him back down to like a lower altitude. And so then ever since he told that story, now I'm like, screw going in mountains, man.
Yeah, very.
I want my oxygenated air. I don't
I'll
need to be
stick with the
going that
main
high.
mountains. They're like 4,000 feet.
Yeah. Right. But yeah, anyway. No, I finally have a healthy dog, knock on wood. Last weekend, I don't know if we even mentioned on the podcast or we were just talking outside the podcast, but my dog Willie, she was very sick and had to take her into the ER actually, the vet ER. Didn't realize that was a thing until I got a dog. And no, she's thankfully doing much better now. But there was a little bit of stressing going on last week when she stopped eating and drinking and was not wanting to do anything. Got a little freaked out, but we got things figured out and she's good to go now. And what are we, day 61 out of 180 days when it comes to her rabies quarantine. So we're getting there. We're almost,
Oh my God.
what are we, 2 out of 3? Dude, we're over 33% done.
That
We're
is
almost at
so
50.
long.
Did I tell you how I talked to this week? I had a phone call with the Minnesota Department of Health and the lady on the call. I was like, yeah, she's pretty much like 60 days since the exposure, blah blah blah. And she was like, if she was gonna actually get rabies and whatnot, she's like, she would have been dead by now. Yeah, she
That's
was.
what I'm saying.
Yeah,
I'm
she
not a
was
vet,
like
of
that.
course, but come on.
She was like the odds because she got her vaccine in time. And she was like, the odds that the virus would have bypassed the vaccine and then not have killed her yet, she was like, is ridiculously low. Like, it's not even possible.
Right, like has it even happened before?
Right. Yeah. So she was like, the fact that you're 60 days in and everything's good, she was like, the last 120 days are basically just to like, we can say with zero doubt that your dog does not have rabies and she can be a normal dog again. So,
33%.
which to that point, we were playing tug today and of course she jumps at me and she actually got me pretty good on my finger and I was bleeding pretty decently.
Jeez.
So I'm like, dang it, Willie. Now I got to monitor you for another 10 days and hopefully you don't get symptoms. Otherwise, I could be in
Now you have
trouble.
rabies.
People joke about rabies being this like when I first told my coworkers about it, they're like, "Should you be in the clinic right now?" I'm like, "I can't transmit it." Like, what are you
Right.
talking about?
You're not drinking my
I can't
blood.
I can't give it to patients. Like, what do we think this disease is?
Nobody knows.
Anyways, I've learned way too much about rabies than I ever thought I would. So if anyone ever runs it, screw personal training and physical therapy. If you're listening to this and you have a run-in with rabies, hit us up. I can give you the rabies 101. I've learned way too much about it. Anyways, let's get into it for the day. We are talking about cervicogenic headaches today, and that's always a term I hesitate to say in the clinic, Christian, because when I say it, I don't know why. I just don't like using medical jargon. And I don't think there's anything more medically jargony than saying cervicogenic headaches. It's like, what the hell did you just say? And so let's break that down about what that actually is. So, cervicogenic headaches, it's a headache. We can get that out there. Cervical relating to the cervical spine, your neck, and then genic meaning, kind of creation. So the neck is creating these types of headaches. Off-ball question for you, Christian. Have you ever experienced personally a cervicogenic headache? Or do you
Yes.
think you have? Yeah.
Yeah. Yeah. Actually, I had intermittent cervicogenic headaches for the last nine years, maybe. It all started when I was in grad school climbing. I fell off the bouldering wall, as one always does, but I fell off in an awkward way to where I got myself whiplash. So I smacked my head
Mm.
and I felt a crunch in the base of my skull. It was just a joint crack. I was fine. But then, like, the next several days, things hurt. And ever since then, I would have pain on the bottom right side of my skull every so often, limited range of motion, turning my head. It came and went. I did massage and stuff for it, but nothing ever really got it that well. And I always felt like I needed my neck cracked. I just like, this is the
Mm.
one thing I feel like would really help me. And then when I went to
Yeah.
my spinal manipulation course a couple years ago, the instructor demoed the manip for your upper cervical spine on me. And immediately after he cracked my neck, I felt just immense relief. And ever
Hmm.
since then, I have had no headaches from that area. It'll sometimes get stiff and tight, but I'll have my buddy crack it now, or I had my coworker dry needle my suboccipitals, and you just
Yeah.
combine those two things, and sometimes I'll do some massage back there, and I haven't had a headache from that area since, and it feels way better, which that
Yeah.
moment made me a massive believer, not just from the research, but also from a lived personal experience of neck cracking can be incredibly helpful for these kinds of headaches, which we will get into.
Yeah. It drew you in. It pulled you in. It
It
got
got
you.
me. Got me.
You dirty dog. I'm just kidding. No, manual therapy can definitely be beneficial for this. We'll get into that. Yeah, it's so weird. I mean, I'm sure there's people out there, if they listen to this, they could probably break down my biomechanics and tell me exactly why I get these. But no, not every time. I play golf probably about once a week and maybe once or twice a month. So every 1 out of 4 times I go play golf. I swing right-handed, and my left, it's cervicogenic headache to the T, and it's always like my left suboccipital, like upper cervical spine, will start to get tight like halfway through my golf round, and I'll just know I'm like, here comes the headache, and then usually about by the end of the round, I have what's called the ram's horn presentation coming up and around, and it like you can really feel like that temporal region. But if I do just like some really intense like pressure and like self massage to that left suboccipital, I can usually get it to go away throughout the rest of the day. Or I might just like pop an Advil or something and it goes away, right? Neck still feels tight, but the headache's gone. But anyways, so that's been my personal story with it too, is yeah, not every time, but 1 out of 4, 1 out of 3 times I play around to golf, I'll get this left originating suboccipital pain, and then it goes up and around my left side. So interesting as to why that happens. Like I said, I'm sure someone out there could break down my biomechanics and tell me what I'm lacking, what's going on, why I get it. But anyway, so we're kind of getting into a little bit of what these cervicogenic headaches are. One of the things I want to get into is kind of what people will generally feel when they have a cervicogenic headache. And so one of the things that I've mentioned, and that's pretty common in the research when you're trying to differentiate what type of a headache this is called the ram's horn presentation. And so if you think about a ram's horn, it kind of goes up and it swirls. It kind of comes back on itself. And that's what people will feel on kind of the side of their head. So they'll feel it start at the neck and it goes up the skull and then it kind of curls in that temporal region. And that's that ram's horn presentation. It's also usually only one side of the head. So it's unilateral. So it's only one side. It's not both. So oftentimes when patients come in and they say they have neck pain and they also have a headache, but they say their headache is just like, it's just everywhere, both sides, behind the eyes, temporal region. Yeah, it's probably not that, but yeah. Anyways, so ram's horn presentation is a very common presentation for cervicogenic headache. Christian, what are some other ways people might be able to tell if they have this type of headache coming from the neck?
Yeah, I think you nailed the biggest one, which is mainly it's going to be one-sided and classically in that ram's horn, but also it can manifest as a single point along that whole ram's horn path. So you don't have to have a whole like continuous distribution of symptoms across the side of your head into your face. A big one is going to be if you move your neck or your head in certain ways, that causes your headache or causes pain in those areas, which if you keep doing it, it can lead to that headache. And that's
Yep.
like one of the major telltale signs that someone has this. If you move your head, that's the problem. That makes you hurt. That tells us something in the neck is probably causing your problem. And then there's, of course, positional things where if you're in a sustained position for a long period of time or an awkward position, that can do it. So we'll see these happen a lot with office workers, people at their desk for a long period of time, staring at their computers, maybe with a forward head posture. Which just puts a lot of tension on your neck muscles and compresses some of those muscles and joints at the base of your skull. You do that for a long period of time, you're going to get pretty sore back there. So you might develop a headache, maybe not initially, but several hours into your workday, or maybe not even one workday, but maybe you get through Monday, Tuesday, Wednesday, fine. But by Thursday, Friday, you've built up enough tension to where you're getting headaches later on in the week. And then in the weekends, you're like, oh, I'm totally fine. It's probably because the work postures are contributing to your symptoms. Next would be lack of range of motion. So your neck feels stiff, and maybe you feel stiff moving to one side, like tilting your ear to your shoulder or turning your head one way or tipping your head backwards or forwards. Having general neck stiffness, especially when you perceive it to be coming from one side, and even especially when those movements cause some headaches, those really make us feel like this is probably your issue. And then lastly, this one's not really a clear cervicogenic headache symptom, but if you can have shoulder and arm pain, usually you're going to have something in your head and your neck as well. But we will see people who have shoulder and arm pain and not much neck pain, but then you go explore their neck and sure enough, there's a tender spot in their neck. You push on that, they can have referred pain into their shoulder. So that's one that we will see.
Yeah. Yeah, absolutely. And the reason I think that's a great point to bring up, and it leads me well into this next thing I want to talk about, which is this article that we based this discussion around. They talk about how basically anything that is innervated by the upper cervical spine, C1, C2, C3, if that is, for lack of a better term, dysfunctional or just not working the way we would want it to work, that can be a trigger point for these cervicogenic headaches. So for example, here's just a list of some of the things that's innervated by C1, C2, or C3. Your suboccipitals, yes. Your diaphragm is innervated by those upper cervical. The SCM, or the sternocleidomastoid muscle, the upper trap, the levator scap, scalenes, and obviously a bunch more things. I just thought the diaphragm was interesting. That's why I threw that in there. But you can see that there's many different muscles around the front of the neck, side of the neck, the upper shoulders, etc. That like if these things aren't doing their job the way they're supposed to do it for whatever reason, that can cause that cervicogenic headache because of that upper cervical spine innervation. Kind of a cool point, also expands on what you were talking about, Christian, of shoulder arm pain as well.
I think one thing to add to that is going to be the trigeminal nerve. Your trigeminal nerve is a nerve that does the sensation of your face and does some muscle function too, but mainly you're going to get sensation issues in your face when you have a trigeminal nerve issue. And the cool thing about the way your body is wired is that those nerves, the C1, C2, and C3 nerves that are coming out of your neck, when they bring signals back up to your brain, they actually mix with the signals that come from the trigeminal nerve in your face. They have like the same kind of nexus or hotspot where they link up and then things go to the rest of your brain. What can happen there, because those nerves are so intertwined, is your body can get confused. And so you can have a neck issue at those areas, C1, 2, 3, but you would get face pain, which there isn't an issue with your trigeminal nerve. It's actually just the mixing of those signals create the face pain. So you might get pain in your forehead, pain behind your eye, around your temple, into your jaw even sometimes. And so anytime someone has face pain, we definitely look at your neck as a potential source for that. And I guess the last thing to add is we've been saying it's that C1, 2, 3. Those are the main areas that this stuff comes from, but it can happen lower in your neck. So the rest of your neck, like down to C7, T1, if you have an issue with the muscles around there, the joints between those different vertebrae of your spine, they take a different path into your brain, but they can still cause these cervicogenic headaches. So like that nexus mixing point of the nerves very high up with the trigeminal nerve isn't the only explanation for your pain. It's just the major one that we see the most often.
Yep. Good points. Good points to bring up there. So I feel like in terms of the diagnosing of cervicogenic headaches, we've been discussing a lot of these different signs and symptoms that you might feel and what we might see. There's two things I wanted to bring up. One of them is they discuss in this article from the International Headache Society. It talks about if you can, they use the word abolish. If you can abolish the headache with blocking cervical spine nerve supply. So they put in an agent to block the signal at the nerve. And if that takes away your symptoms, and then that's like one of the ways they would say, yep, that was a cervicogenic headache. I mean, I think like if we really want to get to the bottom of it, that's one heck of a way to do it. But many times I would argue we don't need to go as far as to blocking nerve supply to figure out the diagnosis. But what are your thoughts on that? And I wanted to also bring up, Christian, your thoughts on nerve block and also imaging to diagnose cervicogenic headaches.
Sure. I guess the first thing to start off with is the diagnostic criteria. I'm not going to go into detail. There's many different big governing bodies that create these diagnostic criteria that we're supposed to follow to figure out, is this a cervicogenic headache versus a tension headache versus a migraine or any of the other hundreds of types of headaches that we have out there. But
so many types of headaches.
So many types of headaches. But the big things that we look for are going to be, do you have decreased range of motion in your neck? And then it does using your neck cause those headaches? Those are very, very big signs for us. And then, of course, we have, based on, this is not the most accurate test in the world, but based on our manual hands-on palpation stuff, if we push on stuff, if we stretch your joints, if those things hurt and they are tense and you're stiff and they cause headaches, those are really good signs that we're thinking about this problem as a cervicogenic headache. And then the last one is going to be, if you have weakness in the very front of your neck, you have muscles called your deep neck flexors. Those muscles have been shown pretty clearly over a lot of years now that if they don't have enough strength or endurance, you are more likely to have headaches. Or people that have headaches, if you kind of go backwards, you see, what do they lack? They lack strength and endurance in those muscles. And so we know that if you treat those muscles, get them stronger, get them more endurance, people's headaches get better. And then one other thing to say is, like, we're always trying to differentiate between tension versus cervicogenic headaches. They are incredibly similar. There's tons of overlap. Tension headaches are caused by muscular tension around that neck, but it's usually more broad, it's more vague. You're not going to clearly reproduce their symptoms by pushing on one single spot. And tension headaches are often made worse by stress or lack of sleep or just other psychosocial things like that, and not so much clearly mechanical like you would see in the neck. And then next you asked about imaging, right?
Yeah. I saw one of your notes on the document, and I wanted to kind of dive a little bit deeper into that. But before we do, a lot of these things can be very similar, and that's why it can be difficult to diagnose at times. Like you mentioned, there's a lot of governing bodies that have differential diagnosis criteria. There's many different types of headaches. They can oftentimes overlap in their symptoms, right? I just think the one thing I want to say, the biggest thing is, as long as we can confirm that this is not, again, going back to like medical emergency stuff, are you appropriate for physical therapy? If you just abruptly develop this sharp headache in the side of your head and your neck hurts and like all these other things, it can be a little anxiety provoking, I could see. And as long as we can see you in the clinic examine, make sure that all of your red flags are checked out. And it's like, all right, this is not a medically emergent situation. There's nothing sinister that we can know of right now that's causing these headaches. It is likely something along maybe a cervicogenic diagnosis. And then we can go forward treating without being worried that we missed anything, right? So that's kind of the big thing when it comes to at least for me, when it comes to the diagnosing of these, because it can be so much overlap, like you mentioned, Christian, with tension type headaches and cervicogenic. Anyway, so I noticed on your notes, Christian, that one of the things was ultrasound and using clinical ultrasound and kind of how that could benefit the patient. So if you wouldn't mind, I'd like to hear more about your take on that and just imaging for this stuff in general.
Sure. Well, there are lots of ways that we can image your neck. The gold standard ways for us to look for a potential cause for a cervicogenic headache, like look at your joints or your ligaments, etc., in your neck, are going to be an MRI. And there are different kinds of MRIs, but a regular one or one that's called diffusion tensor imaging, we can use those to try to look for something. There's also CT scans, which are really good at looking at the joint structures themselves. But those are all very over the top. Like you almost never need those to start unless we think your issue is something else more serious, like a major nerve compression, spinal cord compression, an artery issue, whatever. But if it's like I move my head and it hurts and I get a headache, okay, probably not get the MRI just yet. And one that is becoming more popular among physicians for sure, but PTs as well. PTs are starting to learn how to do this. I think some chiros can do it, is ultrasound. So we use like a pretty high-powered medical grade ultrasound unit to look at the structures of your neck. And we can see, based on those sound waves going in and reflecting back, we can see different color changes. And that can tell us different shapes and densities of tissue. And there's been some good research on using ultrasound to diagnose potential structural issues that are leading to cervicogenic headaches based on the density and the shape of those tissues. Ultrasound is generally really cheap. Like the actual machines aren't that expensive and doing the test is pretty straightforward. So it's cheap from like a materials perspective, but the expensive part is going to be having your doctor do it. And so while it's a pretty cool test and it can be useful to help us find some stuff, you usually don't really need it to get started. And hopefully over time, it'll become much cheaper for us to just use it as more of like let's just double check this area. But by and large, we are going to be diagnosing cervicogenic headaches clinically, meaning you are using tests in your hands and just your questioning and everything that you as a patient are saying. That tells us everything about what's probably going on. And we actually do have a few pretty good tests that we use that give us good reliability of diagnosing these issues, which I'm sure we'll get into in a moment. But then after we get into that, Eric, I'm sure we'll talk more about that injection question you had earlier.
No, yeah, I would agree with some of those points you brought up, Christian, about imaging. I feel like a lot of times I just go back to, as long as this isn't medically emergent, and then something like thousands of dollars on imaging to try and diagnose what's going on in the neck that could possibly be a provocative source for something like a cervicogenic headache. I personally don't think it's necessary as being like first, second, or even third line of defense. But again, who am I to say? That's just my opinion. And then when it comes to treatment, and we'll get into treatment, but when it comes to treatment, let's say if it's facet arthropathy, if I pronounce that word correctly.
I think so.
Or like,
that's how I say it.
Okay, yeah, I don't know. Or if it is like some type of like nerve irritation or whatever it is, like, for us, it's not going to drastically change how we're going to treat you. At least for me, then and how I look at it. It's not like we see images and it's like, geez, yeah, we have the perfect mixture of things to do for that one specific anatomical abnormality. It's like, no, we have a wide array of things we're going to do for a wide array of things. But one of the things that they discuss in the article, Christian, and I brought it up earlier, is this idea of an injection blockade, or blocking nerve signals via agent, injecting it into the local area of the nerve, and then seeing if that improves or doesn't have any change at all on the symptoms. Your thoughts when it comes to utilizing injections to confirm diagnosing?
Yeah. When they work, they can work really well, but they don't always work. And the general idea behind that is you do a couple different things. One is you see an interventional pain physician. They're usually an anesthesiologist or some kind of surgeon that can, using ultrasound guidance, usually they inject a cocktail of lidocaine corticosteroid, or they can do a nerve ablation at the area that they think is causing your problem. And they would have used probably an MRI to find a potential source. And then they look and see what happens. If they inject that area or they do ablation to the nerves that can detect sensation from that painful area, if your symptoms improve, great. That's probably a major source of your pain. And we got to make sure that we're being more specific in our treatment for you if we haven't been already.
Mm-hmm.
And yeah, they work often when that's your main issue. The problem, though, that is very apparent if you've been doing this job for any length of time is that people with these issues don't have just one thing going on. It's not like they have the synovial lining of their left C4, C5 facet joint is the single pain generator. No, dude, the whole joint can be inflamed, and then you got inflammation around that joint leaking out, touching the different muscles around that area, touching different ligamentous structures. And then because nerves are very interconnected and they travel all over, your pain can spread. It can go through the entire neighboring muscles. And so you end up getting all this different stuff going on. You have like the primary fire burning, which is that facet joint, but then you got all these smaller fires all over the place. And you have to treat all of them. All of them contribute to the patient's problem. And so the trouble with trying to be ultra specific in your treatment is that you end up missing a lot of things that need to be addressed. And so like the way I like to go about treating, not saying everyone, but for me, it's try to do your best to find the singular primary source if there is one, but then treat everything else around it. Do all the things that we know are working really, really well for people with these kinds of issues. And that usually leads to pretty good results. And then I will certainly refer my patients to our interventional pain doctor after a period of, let's say, 1 to 3 months of no progress. And we're like, look, we've been doing whatever treatments and you're making some improvement or none at all. This
Mm-hmm.
is the time to escalate. Let's refer you to the doc. We'll get imaging. They'll do an injection and we'll go from there.
Yeah. Yep. Nope. Spoken well. I would agree with all that. Like you said, not always is it of the utmost benefit to be extremely pinpoint in terms of what could be causing it when there's likely many things that could be causing it. Especially if this has been going on for, like in your case, Christian, 8-9 years, right? Like when you have that length of time, probably not just one thing that's causing the issue. So anyway, no, that was good. Moving on. Let's talk about a couple of quick tests that we do in physical therapy, and then we can get on to treatments and kind of wrap things up from there. So, a couple of quick things that we do in PT in terms of trying to look at what are the contributing structures, right? We just talked about there can be many. Well, one of them that we do is called the deep neck flexor endurance test, which we've mentioned the deep neck flexors earlier on in this podcast and how they can be associated with cervicogenic headaches. And I feel like this test is almost like the glute med and glute min testing for the hip. Like anytime you test someone's glute med, glute min, I feel like 9 times out of 10, they're just weak as hell. Like mine are probably not the strongest. And like, just like everyone I test for hip abduction, it's like you just put a finger on their leg and it's huge. Leg just goes down. I don't know. Maybe here in Winona, we just don't work hip abduction that much. Who knows? Maybe it's my population. I don't know. I feel like the deep neck flexor endurance test is the same thing as that. It's like you lie on your back, you give a little chin tuck, and then you barely off weight the head from the bed, and you look at how well that neck is stabilizing, and if your body has to recruit bigger muscles like the SCM, or that the chin tuck falls out of place. There's different things we look for. And do you know, by any chance, Christian, that when I studied for the OCS, this number blew my freaking mind. But do you know the average time that someone should be able to hold a perfect neck flexor endurance test in terms of seconds, the norm?
20.
It's like,
Is that it?
no, it's higher than that. It's like,
okay.
It's like 36 seconds,
That's
which
the
is
norm.
like, that's the norm apparently.
Oh, wait, that's like the norm if you don't have an issue?
Yeah. Like if you can
Okay,
get to
gotcha.
36 seconds. Right. Yeah. Sorry. That was a poorly posed question.
No,
I
I'm
should
just dumb.
never, no, I should never be a writer for the OCS because I would be writing terrible questions. It's like 36 seconds, dude. And like, I remember reading an editorial on that. And even the person who wrote it was like, who the hell thought that 36 seconds is the norm for this test? Like, if you ever, like, for people at home, just try it. Lay on your back, try and tuck the chin and barely lift the head up, and try and hold a perfect position for 36 seconds. That's pretty friggin' hard. I don't know. At least for me, I think it is. And I have yet to see a patient actually get to that, like, timestamp. So, like, everyone I test for, I'm like, technically, it's a positive test because it says 36 seconds. But anyways, so that's the neck flexor endurance test. And so pretty much everyone I see allegedly has weak neck flexors, and so we do some different exercises for that, which we'll talk about next here. But then there's another test, Christian, that we talked about. You want to allude on that one a little bit?
There's one test that actually is much better than the one we just talked about in terms of its diagnostic accuracy. It's called the cervical flexion rotation test. So when you're lying on your back, we bring your chin all the way to your chest. It's kind of uncomfortable. And then we turn your head left and right. You should be able to turn your head left and right 45 degrees. And the whole point of that test is when we bring your chin to your chest and push really hard, we're making it so the lower, like the mid and lower part of your neck really can't move anymore into rotation.
Mm-hmm.
It's like locked, as we call it. But the upper part of your neck is not. So the base of your skull joints. And those joints are the ones that are the most responsible for turning your head left and right. They give you the vast majority of your range of motion. And so when we do that test, if we see that you have under 45 degrees of rotation either way, that suggests to us that the joints at the base of your skull are really tight. And when that happens, it's often a sign that people have an issue there, either in the muscles or the joints, and very likely contributing to your headaches or your neck pain, even if it's still something worth addressing if you aren't really sure as the therapist, because more often than not, if you treat that stuff, people feel a lot better. They're like, oh, I didn't even know I was sore tight there. Like, that's amazing what you just did. Just because it's just a major hot spot, kind of like anyone. If you poke in their upper trap, it's going to feel really awesome if you massage that. Getting to the base of your skull, same thing. The cervical flexion rotation test is a mainstay for physical therapists. We look at that one all the time for folks that have neck pain, just to help us figure out, okay, where could there be an issue? Even if it's not the single issue, it's at least something we should be trying to address.
Yeah. Well stated. All right. So we talked a lot about what cervicogenic headaches are, talking how we can differentiate between different types of headaches, talking about how we diagnose, discussing imaging, etc. Let's get on to the treatment for cervicogenic headaches. So I think there's two ways to separate this out. One is what the research says, and then the next is what we've found personally helps us. You've already talked about manipulation of that upper cervical spine, Christian, but let's kind of touch on what the research says. And one of the things, I think Chad Cook actually came out with an article or a discussion piece on neck pain and, utilizing exercise versus manual therapy, and some other things in there as well. I think we actually did a podcast on that a couple months ago. I don't know. I can't remember.
We've done so many now.
Can't remember if we did a podcast on it or if we just discussed it outside the podcast. But yeah, one of them being manual therapy. And this actually shows to work with a lot of different types of neck pain. When it comes to cervicogenic headaches, things like mobilization, manipulation, and soft tissue work seem to really help people out with these types of symptoms.
Yeah, for tons of issues in your body, it's kind of up for debate how effective manual therapy is for your pain. Like if you pulled your quad or you have Achilles tendinopathy or something. Yeah, I mean, it might help to do some massage work or whatever, but not clearly the most useful thing. But when it comes to neck pain and especially headaches, if your PT or your chiro is not massaging or manipulating, meaning adjusting or mobilizing those joints, things like that in your neck, they are not doing the best treatments that we know. And I feel very confident saying that. We have tons of research on this, and of course, lived experience, personal experience for myself as a patient, but also doing this for patients. You just get far better results if you incorporate manual therapy into your treatment plan. We're going to get into all the different styles that seem to be really effective, but it has to happen. You have to at least try it. If it doesn't work for the patient, fine, but it's a must.
Is that a hill you're willing to die on?
Absolutely. Well, it's also what are you going to do? You're going to have the patient come to the clinic for an hour doing chin tucks? What are they paying you for?
I feel so defeated as a therapist if I yeah, if I sit there and watch someone do chin tucks, like I have them do like 2 or 3. I'm like, perfect, great. All right, you got it down. Now, enough of that. I'm not going to sit here and watch you do chin tucks for the next
Did I tell you
however
that
long period of time.
like a month ago, I had a patient who I was seeing he had a scaphoid fracture, so he broke his wrist, and
Yeah.
he's doing much better. He was recovering. He was just weak and he was stiff. And for his home plan, I assigned him different kinds of wrist curls with bands or dumbbells to do on his own. But when he was in the clinic, I was like, along the lines of just what you said, I'm like, if I have to watch this guy do another wrist curl, I am going to walk out of this building and never come back. And like, I just cannot bring myself to give him those in the clinic. And
Man.
so I just took
Yeah.
to we just started arm wrestling. I was like, dude, give me your wrist. We are gonna just start arm wrestling and just like work on different techniques there. And then
That's awesome.
what's awesome is that the sports medicine doctor that referred him to me happened to just walk into the clinic, and he just like stood there like, is he arm wrestling? I
That's
talked
so
to him
great.
after. He was like, I have never seen anyone do that in the clinic, but
Yeah.
looked really fun, and you keep doing you, Christian. I was like, sweet,
Look pretty cool. Yeah.
I'm doing that. Yeah.
That's great. That's great. Yeah. Yeah. No, I mean, a lot of these exercises, like once you do it once, you got it down and you don't need a whole lot, if any, equipment to do it. And so like writing up home programs for these things, super easy to do. And we'll get into the exercises in a little bit, but no, going off manual therapy though, Christian, I agree. Majority of my time is being spent on hands-on manual therapy work or education to the patient about what's going on and how we want to modify activities, et cetera, for home usage. And so one of the things that they found to be good for this type of diagnosis as well, and this is a manual therapy technique you can do at home, is that C1, C2, those SNEGs is what they're called. And as I say that, I'm trying to think of exactly what was it sustained natural apophyseal glides? Is that what SNEG stands for?
Yeah.
Still got it. Haven't thought about that one. I just always called it snags to patients. I never remember what
We
they're actually
really
called.
like physical therapists are so bad at branding and marketing. Like, who the hell thought that was a really good name to teach patients? Like, I'm going to teach you a snag for your neck. No, this is why
Oh,
chiropractors are way cooler than us, because they just know how to talk to a patient better.
yep.
Anyways, we got to work on the name. That's for sure.
Anyway, so the self snag is a great one to get for home. You can use it with a towel, especially if someone has that positive cervical flexion rotation test like Christian was talking about. And we think the painful spot could be associated with that upper cervical spine, or people just have really a lot of tightness in that upper cervical spine. That C1, C2 snag can really help relieve some of that. So I'll give that one oftentimes as well for these individuals. And it just feels good. Like majority of patients I have that I give it to, when they're doing it, it's like, oh my gosh, this is like almost like someone's coming home with me doing manual therapy on my neck now. Like I can just stretch the crap out of that thing and it feels so good afterwards. So that's another beneficial one as well. And also, like you mentioned with the upper traps and suboccipitals, I'll often just have people lie on their back and just let the weight of their head rest on like my fingertips with my hands like right on those suboccipitals. And I might give a little extra pressure. I might do a little bit of like, pulling or like almost like traction of that upper cervical spine, pulling on the base of the skull. I might add in some different head movements with it. But man, yeah, people love when you just work on those suboccipitals. They're always a good one to do.
Yeah. And then when we say manual therapy, there really are 3 categories of things that are done. One is going to be joint cracking or joint stretching. Those are called manipulations or mobilizations. The other category is going to be anything with needles. So that's acupuncture or more Western-based dry needling. And the third one is going to be massage. There's loads of branded massage techniques, but if you're putting your fingers on someone's sore muscles and you're doing something with that, that is massage.
Mm-hmm.
Manual therapy is all of those. And when we try to think about what works the best for you, if you have cervicogenic headaches, there is a hierarchy of importance. Number 1 in the research for sure is going to be cracking your joints. So cracking your neck is the number 1 treatment in the short term, and it even is very effective over the long term if you do it on its own as a standalone treatment, but also especially when you combine it with other things that work for you. Then next is going to be mobilizing your joints. These are like the less cool version of cracking. Not nearly as immediately satisfying, but they do work really well. It's just the therapist puts her hands on your neck in a certain way and they force the joint to stretch. It's called a joint mobilization. The snags that Eric described are what's called a self-mobilization. So you use the towel to replace a therapist's hands and you stretch your own joints. So joint work is number one, has to happen. Number two, I don't know, this one's up for debate to me. I don't know which one's better. I think the research is coming out in favor of needling. I think dry needling is going to be better just because you can get deeper and you can get into other tissues that your fingers really can't. But from what I've read, it seems like between suboccipital massage or upper trap massage is pretty similar to dry needling, but maybe the slight edge for needling. But Eric, you know more about needling than I do. What
Yeah.
do you think?
How I like to look at it is the most research we have on dry needling really centers around low back pain and chronic non-specific low back pain, to be more specific. That didn't make any sense, but is what we see dry needling to be very effective with. You look at the recent CPG, and I think it has like a B level grade. So not bad, not bad. And so the low back is getting really good research on dry needling. I know that when it comes to the cervical spine, there's not as much research out on it. I think it actually still shows that like manual therapy is just as good, basically. And so
You mean massage?
or sorry, yeah, massage. Sorry, yeah. When it comes to massage, is just as good. But if, and this is kind of pulling a little bit, but if dry needling is showing really good promise in low back, especially around those vertebral joints, and then who's to say that it's not going to have the same effect in the cervical spine, right? Paraspinals, similar. Nerve supply, similar. Joint setup, similar. There's just a lot of similarities between it.
Right.
And so I'll often utilize dry needling for the neck. That's probably the most successful spot when I do dry needling in terms of like immediate relief and overall improving their presentation is doing dry needling to either directly around the vertebrae or suboccipitals or looking at muscles kind of a little bit more outside the neck, like levator scap and upper trap, SCM, right? Those have been personal experience has given me a lot of benefit with patients. And the other thing we know about research and treating this stuff is patients and how they trust you as a therapist. And if a patient comes in and you can present them on dry needling, or they come in asking about dry needling, we often actually have like primary care docs now that send patients over for dry needling. We have educated them on what dry needling is and they know about it. So when patients, reach out to their primary care docs about having neck pain or something, they'll be like, you should go see PT. That's, they can maybe do some dry needling or something. And so patients will come in expecting dry needling. And I always tell patients, when you come into the clinic, I'm not looking to just stick needles in you until we're done with this 45-minute visit. If we can do home exercises, modifications, activity, and some hands-on, I'll say manual therapy techniques, including everything we talked about, more specifically the mobilization stuff, manipulation stuff. If we can get by with that, fantastic. We don't have to stick needles in you. But if you want that type of treatment, or it gets to the point where we want to try that, and then let's do it, right? And a lot of times, patients, if they can, again, going back to the whole idea of trusting the plan of care, what you're doing, and being bought in all the way on what we're doing, that's just going to improve their outcomes probably just as much as any freaking treatment we do. And so dry needling around the neck, not as shown in research, especially when you put it up against things like manipulation, mobilization. But I think personally, from both a psychological perspective and a biological perspective, I think dry needling has helped my treatment for these individuals. Now, to what extent is it coming from, the psychological or the biological? Not exactly sure, but people get better, and that's all that matters. So that's my take on dry needling, and especially around the neck and how it relates to that. Just to reiterate, when it comes down to it, mobilization, manipulation, modification, home exercises, that's really going to be our bread and butter for long-term results.
Yeah. And then just to be clear about the cracking, which are adjustments, you definitely want to crack their neck if you can. If you have osteoporosis or you got a broken bone, of course not. But like If you're good, we should be cracking that. But also, there's been a lot of good evidence to show that cracking your upper back, your
Yeah.
thoracic spine, can really help this because upper backs are often very stiff from just the way that we live our lives. And that can be a major source of postural tension. And if you can alleviate that tension, increase mobility there, people generally feel a lot better. And there's just like a lot of magic that happens in your brain with brain chemicals for alleviating pain after a crack that you don't get as much with other forms of manual therapy like massage and dry needling. And so when I think about what kind of manual therapy to do with people with this issue, I don't want to say I throw stuff at the wall and see what sticks. I just take a systems-based approach. I'm like, okay, I know I should be trying to crack stuff if we're good to crack. I know
Yep.
that needling is going to be helpful, so I'll either do that myself or refer to someone else for needling. And I definitely am going to do some massage because cracking takes a minute. Like that's so fast.
Hmm.
So I'll do that, and then it's like, all right, now let's needle or massage and just get at these different areas and try to do that for a handful of sessions because we know it's not usually going to be a one and done kind of thing. We actually have some research on this that generally it should be about 6 to 8 sessions. That seems to be a good amount of sessions to get someone pretty good. And actually, more than that isn't any better. More than that, in fact, could be too much and make them a bit worse. So, really, 1 to 2 sessions a week for 4 to 6 weeks seems to be about that sweet spot of how often you should have cracking done. Even that seems like quite a bit to me. Usually, I won't crack more than 3 or 4 times over 3 or 4 sessions.
Hmm. Yeah, I would agree. And I mean, when it comes to the exercise, moving on to that, I mean, definitely home techniques to try and get at whatever spots are bugging you, right? If that's using the self snag, or if it's giving certain stretching positions, or maybe just some active mobility exercises, or if it's working on the deep neck flexors, right? Chin tuck and head lifts, or if it's doing isometric loading. We know that there's other parts in the body that heavy isometric loading can be somewhat of an analgesic. And so I like to give a lot of isometric loading around the neck. If it's extension into your hands or side bending or whatever it is, I think all those things are great. And then also working on other parts of that back. You mentioned how the upper thoracic spine can be tight, and that can oftentimes lead to some of this pain discomfort. And so just like how we'd work on it with mobilization, manipulation, soft tissue work, we can also do the same thing with exercises. And so working on some mid trap work, some low trap work, some rhomboid work, getting maybe some of the rotator cuffs involved, just getting some general movement in, I think is also very good. And also we just see in the research as well with that, we just need to get people more active too. So if it's walking, if it's doing an elliptical, if it's doing a daily stretching and resistance training routine for the upper back, even if it's just non-specific, not even related to the neck, like we're just getting you moving more. That's really what we want. And so that's a lot, but it's nice because you can pick and choose for the individual what's going to be best for them. And so when it comes to home exercises, that's kind of my go-tos, and I'll try and make it specific to what the patient needs. But at the end of the day, we just need to get the patients moving and get them to be a little bit more active with that stuff. So your thoughts, Christian, on the home exercises and kind of what you'll give with that stuff.
It's not complicated. It's everything you said. You do 2 major things. You stretch the stuff that's tight, probably going to be upper traps, probably your scalenes. That's easy. That's a classic stretches everyone knows. And then the
Yep.
second thing is going to be you increase the strength, but especially the endurance of your neck and your upper back. If you do those 2 things, stretch and strength endurance training, you're killing it. And so yeah, like the different chin tucks, different neck planks. Huge fan of strengthening your neck. So getting like for people who I see that are pretty athletic, like jujitsu, um, high level contact sport athletes, football players, I have them get a head harness and we put bands on that head harness. We put plates on it and they're doing like chin tucks, forward, back, sideways rotation, and we're just getting that neck yoked. And then, of
Yeah.
course, you do the upper back, so you're getting your rows, your I's, your T's, your Y's, various exercises like that to get them building up their upper and mid back. And
Yep.
then I just wanted to put all this stuff together with a patient story. So I had a patient come to me a few weeks ago. She was a friend of my coworker, and my coworker didn't want to see her for, just conflict of interest there.
Yeah.
But she came to me with pain at the base of her skull on the left side every time she turned her head to her left, and she was severely limited in her rotation range of motion. No major injury, just kind of came out of nowhere. Of course, I screened her for everything else. Everything was fine. And I did that neck endurance test. She actually was fine. She killed it. There was no pain there. But then I did the cervical flexion rotation test when I brought her chin to her chest, turned her head to the right. She was pretty good. It was a little over 45 degrees. Turned her head to the left. She had like 15 degrees. And it hurt. And it caused her pain. I was like, well, damn, okay. This is going to be a joint issue. She was having mild headaches, but mainly it was just the pain in that spot. And so I was like, look, we're going to do a few things. Number one, I want to crack your upper back. And then if that goes well, I want to crack your neck. And then we'll go over tissue work and then exercises. And she was cool with it. So I started with cracking her upper back because some people are weirded out by neck cracking. And I wanted to do one that is totally not going to weird people out. And so we did that one. Her back just like, there's like a million cracks. She loved it. It felt great. And I had her just recheck. She sat up, she turned her head. She was like, it's a little bit better actually, but not that much better. I was like, okay, great.
Yeah.
Wasn't the spot. And then I cracked her upper cervical spine, right side first, and then left side. And after she sat up from that, she was like, turned her head, way more range of motion. She was like, that is like 50% better, just immediately. Yeah. And then from there, did a bit of massage, a lot of tension in her left-sided suboccipital, so the muscles at the base of her skull. I could just feel how tight a couple of them were, and they were very tender. And when I pressed on them, they caused her familiar pain in that area. And so get some massage there. And then got her on a few exercises. I gave her the chin tuck and lift, and I think I gave her one for the back of her neck muscles, and I gave her probably like an ITY or something like that. And I saw her for 3 sessions of doing that kind of split over the course of a month, and she's like 95% better.
There you go.
And now she's just done. She's going to go off on her own. I also gave her the snags with the towel. And so she's doing her snags. She's got her neck exercises, upper back exercises, and she's probably going to be chilling now. And I just told her, hey, if you need more adjustments over time as like a little bit of a boost, you let me know, but you're probably not going to. You're probably going to be totally fine as the next month or two go on. But that was just like a very black and white, simple case of this kind of issue, and just showing all the different tests that we did, all the treatments that we do, and them actually working really, really well. Doesn't usually play out exactly like that. I wish they all did, but it was like the perfect case to describe here.
Yeah. No, that's awesome. Yeah, no, that's I think that's a great way to wrap it up in terms of just summarizing how the treatments can come into play and how it can all work together, like you mentioned in that case. And I don't want to say luckily for her, but kind of like you said, like it happened. It was a good plan of care that worked out very well for that individual. So that's kind of in theory how it should all go. Doing what the research says to do and helping people out with some of that hands-on approach. Yeah, I think that's a good way to end the podcast there, Christian. Is there anything else that you'd want to discuss or talk about in the meantime?
Nope. Just time for you to learn how to crack neck.
I know. That's the thing. You keep mentioning the whole manipulation part of manual therapy. I'm like, oh, I'm just a loser that mobilizes. I don't do any of that.
Guy, you just mash their neck for 15 minutes, just over and over again. It could be over in 10 seconds.
I know.
You're harming your patients. I could argue that.
Yeah. Well, I mean, I don't have that much strength. I can't do blank in that arena. But no, yeah, it's I need to learn how to do that, especially as the research continues to come out and show that cervical manipulation is a good way to go. But no, yeah, thanks for the podcast, Christian. Good one there. We'll be as always coming back with another one. Who knows what we'll talk about, but we'll find something.
We always do. All right, good talking to you, Eric.
Yeah, you as well, Christian. Talk to you later.
All right, later.